Why the sepsis is causing such a huge mortality? Because it is we are failed to recognize on sepsis screening at the earliest. Most of the time, if you see, they will be a normal, looks like a normal. They don't have any laboratory evidence, or they don't have any sudden signs and symptoms. Okay, and under appreciating the mortality, and many times it is being treated like a benign condition, and the time of the critical illness is not being appreciated. Okay, it is always uh, reacted than anticipating the problem. We have a lot of codes like trauma code, semi code. Okay, if the patient comes with the chest pain, immediately in the emergency room we activate the cath lab. Even in the stroke, we have a stroke unit. We activate immediately. We do the thing. But what happens even with this codes after introducing this codes? If you see, the trauma mortality has been reduced from 50% to 7%. Stroke is reduced to 8%. Cardiac mortality has reduced after the interventional cardiology less than 5%. So these all comes when we are recognizing the complication at the earliest and start treating this patient at the earliest. What about septic shock mortality? If you think about the septic shock mortality, this is very old data, almost 50 to 60%. As per the New England Journal of Medicine, almost 22 years ago, it was 50 to 60%, and now it has been increased to almost 80 to 85%. Even in development of our modern medicine, still the septic shock mortality is very, very high. So this is one of the code which is can be used as a septic screening code. Okay, this is can be used as a triage. Okay, so what are the risk factors? You can enroll these patients. Like the patients can be an immune compromised or almost we are in the capital of diabetics. So immune compromised patient can be there, or the patients with the chemotherapy, or the patients can have underwent a recent surgery or any interventional procedures. Now the implanting interventional radiology is increasing, so a lot of implanting devices are coming out. Lines or catheters, long-term catheters, or a recent travel can be a risk factor. So if you look for the symptoms like cellulitis, or having some wound, joint swelling, or dysuria, or the patient having an abdominal pain, some altered mental status, neck stiffness, all
हाँ,
this can
देखते हैं कौन
cause,
सी ठीक ठीक है तो
all this can be the symptoms for the sepsis. So when the patient comes to you in the emergency room, the first question you can ask, does the patient present with any suspected infection? If it is there, then you can look for other two criteria like temperature. If it is more than 38 degree, so we are trained and tuned to look only for hyperthermia. There are a lot of patients, septic patients, they come with hypothermia also. So you have to look for hypothermia also. Look for tachycardia or dyspnea. Systolic blood pressure is less than 90, or the saturation is less than 92% in the room air. We can call it as sepsis. So then we have to activate our sepsis code. Okay. Before going in detail, I will introduce Mr. Ramasamy. He is one of our patient come to emergency room. He is a farmer from a rural southern Tamil Nadu. Okay, his day in day out is, and he wakes up in the early mornings, does all the farm works, and take care of his cattle and comes. Okay, one morning the patient is known diabetic hypertension. Was taking long back, was being seen by the doctor and continuing with the same medication. Okay, and had a unfortunately he had a thorn prick. So he thought that what thorn prick will go. I have seen thousands of thorn pricks in my life, so nothing will happen. Unfortunately, his leg has developed this swelling. Okay, You can see this tantric area. This is a mark, tantric. So he developed a cellulitis and he is coming to the emergency room. His vital signs: the heart rate is 145 with a room air saturation of 88 and the respiratory rate is 32, the temperature of 38.4 Fahrenheit. So now the question is, we want to activate the sepsis as per our code. So as per our code, we have activated the sepsis. So hemoglobin is 8.1, WBC is 23,000, potassium is 4.9, creatinine is 4.2, and the CRP is 180. This is as per investigation. This is an ABG. So ABG shows PaO2 of 48.2, the bicarbonate of 10.01. So what is this picture? Can somebody answer?
Metabolic acidosis.
Excellent. Then any other? Is it a wide anion gap metabolic acidosis or normal anion gap metabolic acidosis? Any guess?
Increased anion gap metabolic acidosis.
So it is a wide anion gap metabolic acidosis. Okay. Okay. And the saturation is very low. So we did an ultrasound. There is some foreign body. So previous history of Thorn is there. So this is the Thorn inside. Okay. Now the question arises: is Ramasamy septic or not? Is he septic or not?
Yes, he is.
How you are saying he is septic?
Or WBC count is very high and CRP is also very high. And he is also having metabolic acidosis. And so there is sepsis is there, BP also I should know, respiratory rate and blood pressure. But there is definitely sepsis and he is having cellulitis. I'm seeing some foci of infection also.
Okay. So now I am being the advocate of devil. So I am arguing in a different way. Is it inflammatory or infective? CRP is increased. WBC is increased. Can I call it as inflammatory rather than infective, or I will consider this as infective?
Uh, it should be infective because the tissue fluid is a good culture media for infection. No, first he must have developed edema, and then because the WBC count is high and so much of inflammatory response is there, so there should be some infection causing such high grade of inflammatory response.
Okay. We will see what is the septic cascade here. Okay. So SARS, there is a terminology. Now it has been removed. Just for a completion sake, I am giving you. When the temperature is more than 38 degree, and the heart rate is more than 90, respiratory rate is more than 20, and WBC is more than 12 or less than 12 or more than 4, we call it as SARS. So SARS plus confirmed or suspected infection, I call it as sepsis. If the patient has signs of end organ damage and patient has an hypotension and the lactate is more than 4 millimole, I call it as severe sepsis. And if the patient has hypotension and which is persistent and not improving with your conventional therapy, then we will call it a septic shock. So now you tell me whether the patient is SARS, sepsis, severe sepsis, or septic shock. Yes.
Did you tell the blood pressure? I could not recall like the
No,
previous
I
slide.
told you it
So,
is 90. Blood pressure
okay.
is 90.
So, and in ABG, I couldn't see the lactate also in the ABG.
Okay, lactate was
Like,
not there in that.
okay. So, it is a severe sepsis. No, it is sepsis only. It is not severe sepsis because there's no hypertension. BP is 90, not less than. There's no sign of end organ damage. Creatinine and all.
Excellent.
Creatinine was high.
Excellent.
High
His
here.
patient is only septic because I'm suspecting the
Okay.
infection.
Hmm.
Okay.
Yeah.
So if
Yeah.
you see the pathophysiology of this, so it is a sepsis is a bloodborne infection. The infection can be of anything, but majority of time we see bacterial sepsis, and sometimes we get fungal sepsis, viral sepsis, parasite, and a few other organisms. Mostly we see bacteria. Okay, there is an overlap between sepsis and SIRS, but in SIRS, it can be seen in pancreatitis, burns, trauma, or patients with a non-cardiogenic pulmonary edema, we see SIRS. Okay, so you should be very clear. Why this is, we need to be very clear because we are going to start antibiotics. For SIRS, we are starting antibiotic. It is again going to cause antibiotic resistance. To avoid that, we are going to know whether it is SIRS or sepsis. Okay. So now we will recognize. Okay. It's a very hard part. Okay. So the end of the bed, we look for temperature change, increase in the pulse, new or changing pain, change in the respiratory rate, decrease in the systolic blood pressure, conscious state. So many times you don't think that the patient will be drowsy. The patient may be delirious, or patient may be very anxiety, or patient may be lethargic. Okay, and the simplest test in the bedside, if the patient is having all these signs, just you can look for a capillary refill time. Capillary refill time we are being taught in the pediatrics can be applied here. There will be a prolonged capillary refill. And the very important thing is whenever there is a decrease in the urine output, this should alert your team to say that the patient will be having some end organ problem. As I already told you, there may be a lot of risk factors are there, especially now. A lot of patients are diabetic going for a CKD. Instead of going for a hemodialysis, they are putting in a CABD devices. We see a lot of CABD patients developing sepsis and coming with hypothermia. Okay. So the symptoms of the sepsis can be cellulitis or maybe wound, rash, dysuria, and increase in the frequency, foul smelling odor, cough, altered mental status, abdominal pain, or having neck stiffness, headache, decrease in the urine output. Anything can be the symptoms of sepsis. So if you look on the broader, we need to address the source of the infection because the source control is the primary one. It is not that you are suspecting a patient with sepsis, starting an antibiotic. It is not going to serve the condition. So we need to know where exactly the source is there. So this is a very important data. You have to look on your local antibiogram and other septic pattern. This is from my previous hospital where almost 35% are urinary tract. Okay, 10% is intra-abdominal, 15% may be meningitis. Septic arthritis is also very, very important, especially in farmers or in the rural area people. They don't give an important because in the older age group, even osteoarthritis mimics like septic arthritis, can mimic like a osteoarthritis or any vascular access, or it may be a skin and soft. Perianal abscess can be there. They don't think of perianal abscess. This can come as a source of infection. And respiratory is other large chunk of 25%. Okay. So how you are going to look? So you do a basic lab parameters like complete blood count, renal function test, blood routine. Ideally, you have to take two blood culture samples in a two different site. And if there is any indwelling devices like permanent catheters or fistula or any other thing, you can take a blood sample from that and we can send it. Ideally, it has to be 30 ml. Okay, not just 2 ml, 3 ml. It is not going to give an ideal growth for that. Do a chest X-ray. Don't look for the swabs. Even swabs can cause a false positive. So take for a tissue culture. Okay, swab can come as an MRSA positive, but the tissue, if you are taking underlying tissue, it will come as a negative. Okay, you have to consider imaging like ultrasound or CT, and again it is a case specific. And if the patient is having some kind of CNS manifestation, you can always look for lumbar puncture. And very important thing you have to know is most of the septic cases, especially the urinary sepsis, they will come with an altered sensorium or delirium. So there you no need to go and do a lumbar puncture. So on a whole, you have to see and then treat the patient. Lactate is very important. It reflects the cellular hypoxia. Okay, there's nothing but hypoperfusion. So it rises early in the sepsis or a shock development. Suppose if the patient comes to you in the emergency room, you are taking a ABG looking for a lactate. If the lactate level is 1, okay, cool, you are starting a resuscitation. After 2 or 3 hours, the symptoms are better and the patient is improving, and you are doing a ABG and the lactate level is rising. It means the perfusion is improving. But same thing, if it has happened after 48 hours, it means that there is uh, deterioration of the patient is happening. So you should be able to differentiate. These two has to be able to differentiate and always repeat and assess for the lactate normalization. Then only you can say that the patient is slowly improving. Okay. Blood culture, as I already told, when the infection is suspected, you have to take. If the patient is having fever, rigor, then at the time it is a high rate of capturing the organism can be there and before antibiotic. But at the same time, just want of taking culture, don't delay your antibiotics. Okay. If the culture, we are going to take a lot of time for taking culture, don't hesitate to start the first dose of antibiotic. Okay. So then we are going to resuscitate the septic patient. So it is called as early goal directed therapy. Okay. And there is a lot of reversal has come with the serving sepsis guideline. The serving sepsis guideline was first started in 2012 and recently 2025 we got a new algorithm. Okay, this is the algorithm. Okay, where early goal directed therapy. So got more amount of fluid, bloods, also active medicine, and very important caveat is very less often they are ventilated. So the hospital mortality was reduced from 46% to 30.5%, but still when the patient got ventilated and taking care, then the mortality is reduced. So goals in the first 6 hours, that is the early goal directed therapy. So you have to maintain the CVP of 8 to 12 millimeter of mercury. But it doesn't mean that all septic patients needs a central line and go for an invasive pressure monitoring. So ideally, in a resource limited environment, what we can do is we can keep your mean arterial pressure is more than 65 millimeter of mercury and make that the patient making urine of more than 0.5%, 5 ml per kg per hour. Okay. And if you have a facility, put a central line, take a mixed venous oxygen gas and look for the saturation. If the saturation is more than 70%, it means that the patient is having. Okay. So this is a beautiful picture where the clinician is armed with the septic bundle attacking the 3 heads of the severe sepsis. So 3 important pathophysiology where we need to address is your hypotension, hypoperfusion, and organ dysfunction, especially the end organ defects. And other important killer is your acidosis, hypothermia, and your coagulopathy. All three has to be handled at the same time. This all three has to be handled properly. Then only you can able to resuscitate the patient properly. So as an emergency physician, my approach is always taking care of airway, breathing, and circulation. Look for the GCS coma scale, and then look for any environmental sources that can give a clue for the source control. Recently, we have been receiving a patient from another corporate hospital, patient having uric hypertension in a very depleted condition. So when we are examining the patient, taking care of airway, breathing, circulation, after assessing the disability, when we are looking for it, we saw a scar, okay, but the patient was not being looked for it. Okay, by seeing the scar, we started the approach is entirely different, and the patient improved after 48 hours. Okay, so that's how we need to treat the patient. So my priority in the sepsis treatment is starting the first looking for the respiratory support, because many times if the patient will be conscious and patient will be in little hypoxic, maybe around 80 to 85%, we will have a tendency to use more of non-invasive ventilation, because we have an idea that non-invasive ventilation will not produce more invasive infections. So rather than going for the ventilatory therapy, we put them on a non-invasive ventilator. But at the same time, if we are failing to maintain the circulating blood volume or taking care of source control, then we are going to lose the battle. So all together has to be taken care of one thing, and then we have to treat the patient. Okay. So this is very, very important. This is sepsis 6 or sepsis ahead. Okay. So give oxygen, take a blood culture, start early antibiotic, fluid challenge, check for the lactate, look for the urine output and monitor adequate urine output. Okay. So respiratory support, why I'm repeatedly insisting on respiratory support, and why I'm giving a priority for my respiratory support in the sepsis bundle is uh, a hypoperfused tissue. Okay, whenever there is an hypoperfused tissue, the oxygen will be depleted. So once the oxygen is depleted, the patient will try to compensate. Our body will try to compensate by increasing the respiratory rate. So whenever there is a respiratory rate is increasing, the compensatory mechanism come into a play. So once the compensatory mechanism come into play, so it will try to maintain for some point. When compensatory mechanism fails, patient goes for a metabolic acidosis. Again, the viscous cycle continue, and again it increases the respiratory rate to compensate. So by giving a supplemental oxygen, we are maximizing the oxygen available. So by increasing the oxygen availability, I'm reducing the myocardial oxygen demand. So whenever there is a decrease in the myocardial oxygen demand, so redox reaction will be prevented. So always use a high flow oxygen in a septic patient, but remember that should be very cautious in a COPD patient or any patients having some kind of a lung chronic lung diseases. Okay, so here don't aim that 100% oxygen. So the guideline says that we need to aim for more than 95%, but in our practical experience, if you are able to maintain 90 to 92%, that is sufficient, because more amount of oxygen when we are giving, this will reduces the nitrogen washout. Okay, it will make more nitrogen washout, so that it will go for a absorption eclectasis, and further secretion deposition will be there. It increases the VAP. So when the lung fails, when the patient is not able to ventilate properly, that is more amount of oxygen requirement is there. You can early start with NIV, but at the same time, you have to have a backup of mechanical ventilation. So initially, if you give NIV, the patient improves for a certain time, and then suddenly they will collapse, go for a sudden bradycardia and arrest. To prevent that, early anticipate the mechanical ventilation has to be done. So in a mechanical ventilation, if you are putting in the patient in the septic patient, you have to follow the ARDS trial protocol. Okay, always use low tidal volume, 6 ml per kg of your ideal body weight. Next class we are going to have what is the basic ventilatory setting, what we do in the emergency room. So here we can optimize your PEEP, keep your plateau pressures less than 30, and keep them in a head elevation of 30 per degree. Always check for the puff pressure, avoid over oxygenation. Okay, hyperoxia again, it will cause more damage to the alveoli and it releases more amount of inflammatory mediators. Okay. Hypotension is always bad. Okay. Whenever there is a sepsis, the vascular will be depleted. So this results further myocardial dysfunction and peripheral hypoperfusion. So all this causes by the hypotension. So when you see there is an hypotension, you have to resuscitate the patient appropriately. So how you are going to resuscitate this patient? Always start the fluid bolus of 30 ml per kg. That is the ideal fluid resuscitation regimen. The fluid of choice is always crystalloid. Okay, there are a lot of trials saying that colloid is better, albumin is better, but large randomized trial across multinational, multi-center trial clearly proven the robust evidence saying that the crystalloid is better. And only one important thing is that when you are using a large volume of crystalloid, hypothermia and dilutional hyponatremia or coagulopathy can occur. You need to be very cautious whenever you are seeing these kind of resuscitating the patient. And most of the old doctors used to see whenever there is a septic patient, they will advise you to give 2 or 3 units of fresh whole blood. That will give more immune competent. Okay, but as per the early gold directed therapy, when the hemoglobin is less than 7, that is the uh, trigger for the transfusion. And if the patient is coronary artery disease or the patient is underwent some cardiac intervention, then the trigger can be increased to 9. Okay, so always look for increase in the BP, decrease in the heart rate, increase in the urine output as your end point for the resuscitation. And invasively, you can look for the normalization of the lactate. So when the patients you are resuscitated and given adequate amount of fluid, still it is not improving. Okay, now we need to improve the contractivity of the heart as well as the cardiac output. Then the option comes to use vasopressors or inotropes. So the we have a armamentarium of vasopressors like noradrenaline, dopamine, vasopressin, adrenaline are available. So what inotrope or which inotrope you prefer? So initially we need to target the mean arterial pressure of 65 millimeter of mercury. Norepinephrine or noradrenaline should be the first choice of vasopressor. Still the patient is not improving, then we can add your epinephrine. Okay, so that can be added. And third one, we can add a vasopressin. Dopamine is the last one because it increases the tachyarrhythmias and it causes more myocardial oxygen demand and it worsens. Initially, there are a school of thought that dopamine increases the renal perfusion, so it increases the renal output, urine output will be increased, and the patient improves. But it is not true because a lot of trials are told clearly that dopamine worsens more than it helps the patient. So this is a paper in 2010, which is a head-to-head tail comparison of dopamine and noradrenaline in the treatment of shock, and clearly given a conclusion that there is no significant, but still noradrenaline seems to be the popular one. And after this trial, lot of clinical trials have clearly proven that noradrenaline is better than the dopamine. And vasopressin can be also added. The low dose of vasopressin is not recommended as a single initial vasopressor. Remember that many times we receive the patient only vasopressin and they will come to the hospital. Okay, it is always a add-on vasopressors. So initially you can start with noradrenaline. If the patient is not improving, as per your institutional protocol, either you can start epinephrine or vasopressin. Okay, so higher dose of vasopressin again it causes vasoconstriction. There are more time we have seen with the digital vasoconstriction causing the peripheral gangrene and all. So be cautious whenever you are giving a high dose. Okay. So always whenever you are giving a vasopressin or noradrenaline or dopamine, whatever may be, inotropes which you are selected. Okay. Then it should be through a central line not through the peripheral line, because even a small extravasation of dopamine or noradrenaline can be a catastrophic for the patient. Even we have seen a patient developing gangrene and going for a amputation of the limb. So it is always advisable to go for a invasive central line. Okay, there is no thing called as renal dose of dopamine. Okay, there is a myth. They say that it increases and increases the renal perfusion, urine output increases, it reverses the renal failure. There are a lot of hypotheses are going around, but it it does not works in a septic patient. So don't use renal dose. Dopamine, yes, it can be also added, and after doing an echo, you can see that patient is having a myocardial dysfunction. Okay, so whenever you want to elevate the cardiac filling pressures in case of low cardiac output, you can start on the dobutamine. And the important thing is dobutamine causes tachycardia. Okay, so you need to be very cautious whenever you are starting dobutamine, because it worsens the myocardial oxygen demand and causes more damage to the cardiac. So what is a appropriate antibiotic? The first dose should be given within 1 hour of entry to a emergency room. We in our hospital we made a protocol that it will be given within 15 to 20 minutes. Okay, the broad spectrum antibiotic will be given first based on our hospital antibiogram as well as our community antibiogram. Okay, this reduces the mortality, and the duration is 7 to 10 days. And also consider antifungal if the patient is having long-term hospitalization or any nursing home, the patient is kept for a longer time, given for an antibiotic for more than 15 days, still the patient is not improving, then you can think of antifungal also can be. Okay. This is a important study and landmark study, and when to start the time. And this has clearly shown that whenever we start the antibiotic at earliest, the mortality reduces very much. So what are the things you need to look before starting antibiotic? Ask for any allergy and any sources. Okay, you have to always look for sources. If the patient is having a source at the lung and you are targeting the kidney, or you are targeting for the any other system, then it is not going to really help you. The patient is having a respiratory source and we are giving for renal, then again it is not going to help. Always think of other site of infections like skin and soft tissue, and other thing like a perianal abscess or septic arthritis has to be think. Always look for any previous hospitalization, previous antibiotic are given, and then we can think of that. And immediate culture and sensitive, whether the culture and sensitive has been uh, done in a previous hospital, or if the patient comes directly to a hospital, send for the culture and then you can start. Lot of papers they are saying that we can use early steroids. Okay, and there are few papers contemplating the same finding, saying that by using the steroids it worsens the condition. So now the question arises whether the steroids can be used or causing. So this is a paper in New England Journal of Medicine in 2008. It is again one of the landmark trial, saying that the hydrocortisone therapy for the septic shock, the pendulum swings till now, and still they say, somebody says it is good, somebody says bad, still the pendulum swings, it not come to a halt. Okay, so whenever there is a vasopressor resistant shock, then we can think. Okay, so don't go for stimulation test in a septic patient. It is not going to help you out. So whenever the patient is not responding to two inotropes and still the patient is in a shock after adequate fluid resuscitation, then you can consider of steroid. Source control is a very important. Unless you control the focus of infection, how much amount of antibiotic, tons and tons of antibiotics you are giving, it's not going to really help. So as early as you are going for a source control, then we can do it. Except a peripancreatic infected necrosis, we need to delay. Other than that, we can go as early as possible and try to remove the source. Like drainage, intra-abdominal abscess or perianal abscess, thoracic empyema, we can go for it. Or necrotizing fasciitis or patient developed pancreatic necrosis, then you can go for a debridement. Or if the patient is having a pseudocyst that has been infected, then you can go for a drainage. Or the patient is having some vascular catheters, Foley's, then we can go for a device removal. And if the patient is having certain infections like uh, cholecystitis, or the patient is having ileitis, diverticulitis, then we can go for any resection or surgical removal. Okay. So as I already told you, the transfusion trigger is only the hemoglobin is less than 7. We go. There is no role for erythropoietin as a specific treatment associated with severe sepsis. And FFB should not be used to correct the laboratory clotting abnormality in the absence of bleeding. Okay. Many times, if there is an coagulopathy, giving FFB is just adding fuel to fire. It will worsen the condition. So don't do that. Okay. The prophylactic transfusion comes when the platelet is less than 20,000. Otherwise, no need to even go for a platelet transfusion. Renal replacement therapy, yes, definitely it is. CRRT is always preferred to a hemodynamically unstable septic patient. If you are not having CRRT, then you can use sludge. Okay, flood can help you out slow, and the low efficiency continuous dialysis will also be equivalent to CRRT that responds very well with the severe sepsis. Not only it clears your acute kidney injury, also in doing a CRRT, there are incidents where the cytokines also can be filtered and removed. There are new gadgets are there like cytoabsorb filters where septic filters are there, resin dialysis, where when we are putting the cartridge and when the blood is done through the CRRT, the cytokines, inflammatory markers, and procoagulants are all removed. So that helps the patient to improve. There is no role for immunoglobulin, selenium, activated C protein, continuous bicarbonate infusion, some immune modulating things, there is no. So whenever the patient is admitted in the emergency room after stabilization, shifting the patient in ICU, you always look for your fast hug bleeding. Okay, so it means nothing but feeding. Look for pain control, sedation if needed. Go for a the patient is sedated and when ventilated to queue for a sedation holiday. Thromboembolic prophylaxis has to be given. Head and elevation, ulcer prevention, glucose control, spontaneous breathing interval, bowel function, remove the indwelling catheters as early as possible. This is very, very high mortality is there. So it is always advisable to involve the family early and often whenever the patient is elderly or having multiple comorbidities, always discuss the patient to avoid medical legal complications. So the complications of sepsis like shock, oliguria, CNS dysfunction, ARDS, lung injuries are based on the duration. The patient will be admitted to your hospital with little altered sensorium. Then slowly the patient will worsen, go for oliguria, shock, ARDS, and acute lung injury. Then the patient will start accusing you. Patient came and little having some problem, then you have made it more worsen. So it is always better to discuss this at the earliest to the family. So, what are the endpoints for the resuscitation? Increasing in the systolic blood pressure, decreasing your capillary refill time has been in the extremities becoming warm, increase in the urine output, mental status improving, and then the patient's lactate is normalizing. So, so this is a new app where you can put all the tool and try to get as we are in the digital era. Okay, this will tell you whether the patient is in the SARS, severe sepsis, or septic shock. Okay, so to conclude, sepsis is a time-sensitive disease, just like your MI or your stroke. So always suspicious, look for it. When you find it, try to fight. Hit hard, hit fast. Requires early active intervention. Okay, whenever you see some kind of cellulitis, immediate debridement is needed. It is not that I will wait for the next day. I will ask the surgeon to come in the next day. Morning we will do. No such a thing. So whenever we see, it has to be hit hard, hit fast. Requires very early intervention. Antibiotics and fluid should be started within an hour. Always remember sepsis kills. So it is better to recognize, resuscitate. If you are not able to manage, refer the patient to the higher center. Thank you. Any questions? Any questions?
Sir, in the chat box, there are some questions.
Yeah. Okay. Can you please repeat lactate in first 2 hours and another after 48 hours? Yeah. It means in the first hour you are taking a lactate. At the time of that is 0 hour, you are taking a ABG. You are looking for the lactate. Lactate is high. Okay, or it is normal, and you are resuscitating the patient. After 1 hour, you are repeating your ABG. Now the lactate is little high. It doesn't mean that the patient is worsening. Look for the symptoms. If the patient is symptomatically improving, vitals are getting better, but only lactate is little increasing means it means the perfusion has started. But if the patient is having a normal lactate and after 2 hours also it is normal lactate or having little increase in the lactate, after 48 hours the lactate is rising more, that means really the patient is deteriorating. You have to give more importance to that lactate value. Am I clear? What about post-sepsis syndrome? Yes, post-sepsis syndrome, just like a long COVID, we have a lot of patients going for critically ill neuropathy, critically ill muscle weakness are there, and the patients going for ICU psychosis, or the patients going for they will be normal, they will be looking like a normal, but they will tell you that I'm not having an enough adequate appetite, or my gut is having some kind of fullness. These are the things, so we have to address this. Vaccine in vulnerable poison. Yes, vaccines will definitely reduce the sepsis, just like ARDS and the flu can be given in the diabetic patients or renal replacement patients or continuous patients on renal replacement therapy. We can give flu vaccine that reduces the pneumonia. Any other questions about this? Decision to take patient for dialysis, urine output or serum creatine? Urine output. So if the patient is anuric, you have to take, or oliguric, and there is a doubling of creatine, then the condition is worsening, then we have to go for dialysis. So wait for 4 hours. If the continuously the urine output is decreasing or it is anuric, then we will directly go for early dialysis. After noradrenaline, which vasopressor should be chosen? Yeah, after noradrenaline, you can either choose epinephrine or vasopressin. Depends on your institutional protocol. If the patient is in shock on NORAD with heart rate of 150 or more, how to proceed? Yes. So look for adequate tachycardia. You have to think of fluid. The fluid has to be given. Optimal dose of fluid has to be given. Then you think that the fluid is given. Then look for any fever or pain, or the patient can be having some kind of thing. If the patient is intubated, okay, and patient is not being adequately sedated, or the patient is intubated, paralyzed or not sedated, then these kind of pictures will be there. You have to look for it, but you should not treat this tachycardia, okay, just by giving some beta blocker or ivabradine. You should not do this. This will immediately decreases the catecholamine surge, and then patient will go for cardiac arrest. Don't ever give this. I have seen in a patient with a DU perforation taken for a theater, After resuscitation, the heart rate is almost 120. When the patient came, it was 250, and we resuscitated the patient. Surgeon was told and taken to the theater. Anesthetist was not aware of this. Just like that, he entered into the theater, saw the patient having a heart rate of 120. Before inducing anesthesia, he gave beta blocker. Then the patient went for cardiac arrest. He couldn't able to revive. So don't bother about this. So adequately look for the underlying conditions. Role of procalcitonin, yes, the procalcitonin has a better role. And if you have facility and a financial part of the patient is okay, then we can do procalcitonin. Procalcitonin, now again, procalcitonin, even in the tropical fever like malaria, scrub typhus also, it is increasing, but it is not increasing in a larger value. So we can look for it and we can make it in our own cutoff value, then we can treat. In our hospital, we have having a procalcitonin cutoff value of 50%. If it is more than that, then we consider this as a sepsis. Prophylactic antibiotic in mechanically intubated. Again, it depends on your ICU antibiogram. Okay, in our hospital, we start with piperacillin tazobactam, or if the patient is already started and the patient is having a respiratory complaint, then we go for a norepinephrine. Initial and maximal dose of norepinephrine. Initially, we start with 0.01 mics and maximum of 0.3 mics per kg can be the maximum dose. So, any other questions? Thank you. Good night.